I love that music. Good morning, Kansas City. This is Steve Stites, Chief Medical Officer at the University of Kansas Health System. I'm here broadcasting from the Dolph Simon Studio with my friend and colleague, Dana Hawkinson, Dr. Hawkeye, as you've heard we've said by now. And we'll be joined this morning by the Chief Medical Officers of 3 different places here in Kansas City. And just as a comment, when this COVID crisis came, a number of us got together as CMOs, and we started calling and said, let's have a group call, and that went from once a week to twice a week to 3 times a week, and I have to tell you, it's been great.
Yeah.
In many ways, we're competitors, but in this way, we're all in it together, which means that we're trying to help take care of patients with COVID disease in a coherent, organized, cooperative fashion, and I think it's never been better. So on the phone with us this morning is Mark Steele, who is the CMO over at Truman Medical Center. Mark, you're out there?
I'm here.
Excellent.
Steve.
Thank you.
Good morning.
All right. And then Raghu Adiga, who is the CMO at Liberty Hospital. Raghu?
Yep, I'm here.
Awesome. Larry Botts, at CMO over at Advent Health Shawnee Mission Medical Center. Larry, good morning.
Good morning, Steve. Thank you.
Thank you guys for joining. Let me first just turn to Dana, and then I'll go back to each of you, and you can kind of tell a little bit about the story that is going on with your places. Dana, this morning, what's our count look like?
Yeah, so many things to talk about, but our count, currently we have 24 patients in-house, and 11 patients, 11 of those are in the ICU, but we are still looking at ruling out about 21 patients for new disease.
Kind of flat, maybe even a little lower, so yeah we're happy about that.
We'll see, and some of these have been taken off of isolation because they have been here for so long and are actually recovered, but we still count them in our numbers.
Hey, and Dana, just a quick thought. Emerging news story about these 2 people in February, in February now, in California, without a travel history, who were positive.
This is, this speaks to the insidiousness of this virus, and this will help a lot of people.
You just made it very evil there. Insidious is such an evil word.
We don't like to anthropomorphize this virus at all, but the way it spreads is very insidious. And there have people that have asked me, I had this illness back in December, I had this illness in January, do you think it was COVID? And from the best evidence that we had, I said no, because also there probably weren't a lot of other people that got it when they were taking care of you. We weren't doing those therapies. But now, this new evidence is, well, maybe there were people that actually died in California way before the original Washington cases. So I think there are still a lot of questions to be answered, and as we move further in, hopefully we'll get those answers. And
it is time creep as we watch it kind of go back, and we keep
and that, I think that also plays into the fact that we understand this virus can spread so easily, and we thought that it was an R0 or reproducibility or infectivity of 2, meaning that one person would infect 2, but it's probably more like 5. And so when you have one person, they have a high likelihood of infecting 5 people, and those 5 people have 5. And so this is how we can get exponential growth, and this is why we are really stressing the physical distancing for all this to really stop the spread.
And knowing that there was travel back and forth between China and the United States forever, and so when people were coming out of Wuhan in December who may have been in contact with the virus, they could have easily come here and given it to someone and then gave it to someone else. And because so many people are asymptomatic with it, they probably are mildly asymptomatic. They say, I have a cold, and it wouldn't have been a surprise. So Mark, let's turn to you next over at Truman, and how are things going over at Truman Medical Center?
Well, Steve, things are going well. Good morning to everyone. And so currently we have 4 patients in the hospital here at Truman. We've trended down a bit. We were at a peak of 12 last Tuesday. And currently we have 2 in the ICU, and 1 patient is on the ventilator. And we have 11 patients pending testing who are in-house currently. We've actually discharged 32 patients to date, and discharges are a big deal for us, like I'm sure they are for everyone.
We celebrate those.
Yeah, we do. We actually play the Rocky theme song overhead in the hospital, which is very uplifting for everyone when they hear that. Like others, we're doing the drive-through testing. We have stations both here at downtown campus and out at our Lakewood campus. In-house testing recently became available. Our testing was somewhat limited prior to that, so we were only testing our TMC patients, but we just recently expanded our capacity, and so we've opened up testing to all the residents at Kansas City and Jackson County. Interestingly, and like others, our testing at TMC shows those who identify as African American have 4 to 5 times the positive rate as those who identify as white. And that's one of the reasons that we decided to take our testing into the community, since some of our folks have transportation issues and can't get to us. So yesterday we were actually at Morning Star Baptist Church with our mobile van, and we tested 37 people there. Today we're scheduled at St. James United Methodist from noon to 4, and Friday we'll be at Second Baptist Church at 39th and Askew from 10 to 2. So we're excited about that. Anyone out there who's interested, we ask that they call 404-CARE, which is 404-2273, to set up an appointment if they want to drop by and get tested. We're testing only individuals who have symptoms. Like everyone else, we continue to do everything we can to source PPE. We still struggle with that a bit. We are accepting donations, and anyone who wants to donate masks can go to our website at truemed.org. So that's kind of what's happening here.
And that's great. And you all have a special mission and so appreciated. So I think that going into the community like that and having testing sites is especially important. Do you find that, and I think you said this, that there's a higher rate of positive tests in the African American community than in other areas that you serve?
Yes, absolutely. So yeah, as I mentioned, 4 to 5 times higher than the population identifies as white.
Dr. Adiga, up in Liberty, how are things?
We've been pretty lucky here in the Northland, as you know. Our numbers as we stand today, we have only 2 patients in-house, and they're all getting better and looking forward to getting out of the hospital. And we have 4 that we are waiting on the test results from overnight. And we've been pretty flat over the last week or 2, luckily. Otherwise, as you know, like everyone else, we've been working hard, mostly in our preparedness all along. The things that we started early enough seems to have helped quite a bit. Preparing all our staff, educating them, and putting in place the PPE conservation measures, and getting the doffing partners trained, putting in engineering controls. Those seems to have helped a lot. We did start our drive-through testing. It's been almost over a month now, and we gained a lot of experience doing that. So locally now, the Clay County Health Department is wanting to start their own to help the community, and we provided a lot of assistance in how to do that, and that should be starting pretty soon. And for our patient population also, the telehealth has helped quite a bit. I mean, already in April, we've done well over 2,000 visits just to keep, the other side of things is patients not getting their care and somehow trying to reach them. I think telehealth has helped quite a bit. And one other thing that we've been pretty lucky is the number of healthcare workers who have had positive testing or infections. Out of 1,900 employees that we have, so far we've had only 5, and all those 5 seems to be pretty much community onset. So the training that we have provided about appropriate use of PPE, that seems to really have helped so far. And of course, in the Northland, I think our sparse population as compared to inner city obviously helps in addition to stay-home orders. And in Clay County, as you know, so far we know only about 57 cases, in Platte 27, and Ray County 7 cases, as compared to hundreds elsewhere in the region. Speaking, like what Dr. Hawkeye mentioned, I'm also pretty curious about all these epidemiological studies. There is an article in NEJM last week, if you looked at it from Iceland, that's very intriguing to look at different ways of studying the population. One take-home from that is that for every patient that presented to healthcare, there were 2 patients with mildly symptomatic or not symptomatic in the general population that they found. And so that goes to, the point of these asymptomatic people who were spreading way before we even knew about it, and brings home the message of importance of social distancing still needing to take place.
Yep. Good hand washing, don't touch your face, all the things we talk about. And Raghu, I think, as I recall, you're an infectious disease physician as well, right?
Yep.
You and Hawkinson.
We know each other very well, Dr. Hawkins.
Yeah, I know.
Yeah,
you guys can sit and geek out about some of this epidemiological ID thing, which is good for the rest of us. And by the way, I'm a graduate of William Jewell College a long time ago. I'm not going to tell you how long ago it was. And so take good care of folks up there. So, Larry, over at Advent Health, how are things there?
Well, thanks, Steve. Currently, we have 11 COVID-positive patients. We have 0 patients awaiting tests because we started in-house testing yesterday afternoon about 3 o'clock, and we have a turnaround time that's fast enough that we're now ruling out everybody in the ED. So that has been really helpful for us so far, and will be helpful in the future in preserving our PPE. Out of that 11 people, we have 2 people on ventilators. So I think it's the experience at other institutions in the region. We've seen kind of a stabilization in the number of hospitalized COVID patients. And in fact, here at Shawnee Mission, we've had a steady decrease in our numbers since our highest count, which was 26, and that was back on April 6th. So we've had a steady decrease since then. We've had well over 100 discharges, which is always encouraging to the frontline staff to see those people get to be discharged, and we celebrate those quite a bit. It's an encouraging trend, I think, and I like Dr. Stites has said before, I'm an eternal optimist, and I hope we've seen the apex in our cases, but we'll see how that goes. We've also been fortunate, and we've been able to participate in a Mayo Clinic trial using some convalescent plasma. That's in conjunction with the Community Blood Center. We've been able to treat 3 patients so far, and I think a 4th upcoming with plasma that's been obtained from patients who've recovered from COVID-19. It started with our first patient we treated back on April 12th. I know others in the cities are participating, and I think the results from this national study are going to be important in the treatment of the virus as time goes on. We'll see how the results are. At this point, I think I'm going to put in a plug for Community Blood Center. They are looking for eligible patients to donate. So anyone who has had a positive test, have recovered from the illness, and haven't had any symptoms for 14 days are in that eligible category, so they can donate.
And Larry, I'm sorry. Go ahead, Larry.
Yeah. No, go ahead. That's right.
I was just going to say, Larry's, I've known Larry for a long time. He's a pulmonologist and has been working in this capacity over at Shawnee Mission for a while. And like all of our partners on the phone today, does a great job. Anything else you were going to add?
Well, I just wanted to thank you and the staff at KU for hosting our biweekly Chief Medical Officer calls in the last few weeks. Those calls have been extremely informative to me and helpful as we share best practices and better understand what everybody in the region is doing. So I just want to thank you.
You bet. Thank you very much. It's been great, and it's one of the things that has brought us together in this crisis. So, all right. So from our media friends out there, are there questions for anyone here on the panelists in our panel this morning? As we wait on that, just a quick note about tomorrow. We have a bunch of lab testing experts coming. The head of our micro lab and our kind of that part of analytic chemistry, Fred Plapp, Rachel Eastman, who runs the testing program, and Rick Coldery, VP of Ancillary Services, will all be on the program. And then on Friday, Jessica Callender-Rich, who will be helping head up the Wyandotte County Task Force for Long-Term Care Facilities and around a lot of the questions around COVID as well. We'll be on, and Senator Moran will be back talking about the $25 billion funding for testing. So just a heads up about those things. And then questions from the media or from Facebook, anyone?
I do have a question here. A reporter is asking.
Oh, here we go.
Vented patients in New York have an 80% mortality rate. What are your thoughts? You may
Yeah, you bet. So there's a question from a reporter that that patients in New York who are intubated and mechanically ventilated have about an 80% mortality rate. We're seeing a much lower mortality rate here, and I think I'll have our guests comment as well. I think ours is around about half of our patients are being liberated, maybe 40 to 50% are being liberated from the ventilator. There's a few now, it's hard to say because I think hopefully they'll come off too. But that still is a higher mortality than most of us that have practiced pulmonary critical care are comfortable with. But it is, and we have to put it into perspective because it's a very low mortality rate overall. But it is, once you get intubated, it's a little more difficult story. Larry, what would you say yours has been like at Advent?
Yeah, I would agree. I think our it's been around 40 or 50% of people who have been able to come off the ventilator and successfully go. I don't have those exact figures, but that's the generally I think that's about right.
And Mark or Raghu, any thoughts about that?
No, our numbers have been small, but the ones who were intubated here have been successfully extubated. So that's been good here.
Yeah.
At Truman, we've had few patients on the ventilator, but I mean our mortality rate's over 50%, probably not quite 80%.
Yeah, and I'm hoping that will continue. That trend continues for us, and I think all of us have experienced this flattening of the curve. Which just a shout out to, we said BKC, and we think that's happened. People have done a great job on the sheltering in place and staying at home and 6 feet away and all the infection control precautions we've talked about so much. I also think that our lower population density has helped. I think the next big challenge for us will be as we explore reopening society and people getting back out there in public. Remember that the rules haven't changed. The sheltering in place has changed, but the 6 feet away, washing your hands, don't touch your face, cough into your elbow, those things are still true. And you have to do that especially because you don't know who has the disease and you don't know who doesn't have the disease. And I think that strikes back to the things we're seeing about having it in California in February. It's probably been here since December, realistically, because it was in December, and if it was in Wuhan in December, and people are traveling back and forth and they can be asymptomatic carriers, Dana, I bet it's been here for a while.
Yeah, and the best evidence they have right now is that maybe in November early is when it initially started in China. So we really don't know. Hopefully we get more of that information. But the other thing to do is, again, if you are having symptoms, if you are sick, call your doctor, but please don't go out in addition to all of that. So hopefully we will learn more, and we just know, again, that it can spread so easily, and even if you are asymptomatic. So that's the big.
And any comments? I think yesterday you were talking about a home antibody test is going to be out pretty soon that the FDA has approved. Any comments about that? I believe it's from LabCorp. You got to send it in, so probably
I think we still need to wait on that. Again, I think there's still the same caveats. We've been talking about serology or antibodies. We need to make sure that it is actually the novel coronavirus that they're detecting. Also, make sure that we still don't know how much immunity you have just from detecting the antibodies. We can hopefully get more comments from Dr. Plapp and Dr. Leisman and Rick Coldry tomorrow with our lab services. But all of this, hopefully, as we move forward, is going to be better vetted, better validated, and ultimately lead to better protocols and procedures and getting people back out and doing things, but still keeping people safe, obviously.
Yeah. Other questions today?
This is Jim Brabish from Kansas City Medicine, Kansas City Medical Society.
Hi, Jim.
Our panel, do you have stories that you could share of physicians in your hospitals who've been making extra effort during this crisis? Any great stories to tell?
Mark?
Doctors?
Mark or Dr. Adiga or Larry, thoughts about that?
Well, I'll make one comment. We have a hospitalist group here who has done an outstanding job of being able to put a small group of their physicians as our COVID physicians, and that has decreased their exposure, one, and secondly, increased their experience. Those people are working pretty hard because there's only 4 of them. They're working 7 days, 7 days on, 7 days off, and I've really really want to thank them. I think that was something they stepped up and volunteered to do early in the course here, and I think it's helped us quite a bit. So.
Mm-hmm. And this is Dr. Bott from Shawnee Mission event. Who was just speaking?
That was Larry. Yep.
Okay.
Yes, I'm sorry, I didn't introduce myself. So.
It's all right.
This is Raghu Adiga, and again here in Liberty, also, we have several. It's not, one individual physician that I can point out, but there have been a group of physicians among hospitalists and a couple of anesthesiologists and ED docs and a critical care doc who kind of stepped forward in caring for these patients, on a priority basis and making their so-called, COVID team. Taking care of them, all the time, developing policies and treatment protocols. So it's been very heartwarming to see people step up.
So this is Mark at Truman. I would just say in a general way that I've been so impressed with our medical staff, the time and effort that people have put forth in terms of preparation and planning, and the collaboration between the specialties has just been phenomenal. So it's not any individual, but a team effort, and the team has really done a spectacular job, I think.
And I just say that I think it's an interesting time to be a physician or a healthcare professional. The first thing I'd just point out is that the nursing staff's often on the front lines of this, and they're the ones in and out of the rooms and have the highest risk of exposure to COVID-19. And so I think hats off to the professionalism of folks at that level. And physicians as well, as you mentioned, the ED staff, the ICU staff, the hospitalist services. The remarkable thing about that story is it's happening at the same time that by cutting elective surgeries and by closing down ambulatory clinics, a lot of physicians are going to see less compensation. So some of you are working in a greater danger zone, really, and your comp may well go down because there's not as much revenue coming in because we don't have as many people in the hospital. And so, boy, that's kind of an unparalleled time in my life as a physician. And you've heard me say before, and everybody says I'm old, and they don't want to hear about it. But the AIDS crisis is the closest thing that I remember to this. And AIDS was awful and devastating. And I'm not sure we've talked enough about some of the similarities or some of the dissimilarities between what happened in the late 80s and early 90s and what's happening today. I think there's a story there that's pretty remarkable. So, next question.
Hi, this is Melissa from Channel 41.
Good morning. Go ahead. Channel 41.
Good morning. I'm sure you've seen the news that came out yesterday about the effectiveness of hydroxychloroquine, and I was wondering your thoughts on that and if you've seen the same results in the testing and the usage you've seen in your hospital.
Yeah, let me turn to Dana to talk. And then Dr. Adiga, with your history as an infectious disease doctor, I'm going to bug you about that too.
That's a great question. Everybody is working to try and find a therapy, a drug to treat this disease. I would like to echo the thoughts about Community Blood Center. If you're a recovered patient, please contact Community Blood Center because we are working on convalescent sera treatment or antibodies treatment for patients who have it now. So please contact them if you're recovered so they can get your plasma, and hopefully we can use that, and that may be a promising drug to use in the future. So as far as hydroxychloroquine goes, we have had an excellent therapeutics group with Dr. Salate, Dr. Barr, Dr. Castro, our infectious disease pharmacists, who have been on the front lines of looking at the newest and best data that they could to try and put together algorithms and criteria for giving drugs to people who have COVID-19. One of those drugs was hydroxychloroquine. The other was azithromycin, and using them in combination. There were other recent articles and NIH guidelines that said don't use that in combination that came out yesterday. I'd like to point out that our group pulled the combination of hydroxychloroquine and azithromycin probably about 2 weeks ago because one of the articles that touted it actually lost support from the journal that it was published in. So we have been constantly monitoring and keeping up to date with the newest trends and hopefully the most accurate data from these trials. But unfortunately, a lot of these trials maybe weren't done under the best circumstances, weren't strict. Some of the publications, maybe weren't accurate. So that's the best that we had to go off of. As far as our experience here with hydroxychloroquine, I don't have any specific numbers. We have certainly used it on a lot of patients, along with some of the other drugs that have been looked at and used in trial method. Again, we're using these under criteria to really get the data to see if they are efficacious, but mostly to make sure that they're not harmful, because we know that some of these combinations or some of these drugs can be harmful, and we don't want to do more harm.
And Dr. Adiga, from your perspective as an ID doc, thoughts about hydroxychloroquine, old medicine, not a new medicine, but new application?
Yeah, I agree with Dr. Hawkinson. We've been watching that very closely as well. And hydroxychloroquine by itself, yes, we do use them still in seriously ill patients hospitalized, but I personally have not been terribly impressed. We still have to wait for the phase 3 trial results to be absolutely certain. And as Dr. Hawkinson mentioned, we also kind of followed the combination therapy in the beginning using azithromycin with hydroxychloroquine, but about a couple of weeks ago, we also stopped using that since the data was coming out. Yeah, it's very interesting, and there are guidelines that are already put out by IDSA and NIH, and most of those, to paraphrase one of the reviewers, kind of tells you that don't just do something, but stand there has been the recommendation. So it's a very difficult time when you don't have the data to start using everything that's out there and then figure out later on that it could do more harm than good.
Yeah, and the importance of trials and science in that. And I love that. Don't just do something, stand there. That's pretty good. I'm going to steal that, Hawkeye.
That was Paul Sachs, one of a brilliant mind. But when he was reviewing, as Dr. Adiga said, it's like we, as physicians, we want to treat you. We want to make you better. So we need to do something. But we want to make sure that the thing that we do is not more harmful to you as well.
And just to say, for those of us, I'm sorry, go ahead. I was going to say, for those of us in the trenches, one of the important things to have is a little bit of humor now and then. So I appreciate that. Hawkeye here sends me these little clips late at night of somebody doing some kind of monologue about coronavirus. I call it Corona humor, and it keeps me up. But it also, that humor is so important at a time like this. So yeah, don't just do something, stand there. That's good. Mm-hmm. All right, next question.
MyTown Media, Larry Pierce, thanks for taking my question, sir. Speaking of humor here, this is a story that I found backed up here, but I know there's all kinds of questions you get about the transmission, but now some Australian and doctors and scientists there are now saying that the virus could even be sped through flatulence. And I could have swore I've seen you guys talk about if this virus was to get into the stomach, that the stomach bile would eat that away. So I'm just kind of curious where they might be able to come up with something like that.
Okay, Dana, you're going to take that one on. I'm not touching it. No, I will. And actually, we know it's in stool, so.
Yeah, so that's the biggest thing, as Dr. Stites had said. We know it's detected in stool. There are a lot of reports about being detected in various body fluids. Blood, secretions from your eye, obviously respiratory secretions. It's been widely recognized that you can detect it in stool. It's unclear if it's infectious virus, if it's live virus, if it's whole virus. There have been a lot of reports. One of the most recent reports I saw was that they actually tried to culture, though, from stool, but they weren't able to actually culture it. But I think we still need a lot more data as far as that goes. As far as in flatulates, I mean, I guess if you're blowing hard enough and it's in the anal swabs and you can detect it, but I would say probably not. But again, we know that it can be detected in various fluids or secretions, such as the eye, the respiratory secretions, stool, things of that nature, blood as well.
And hopefully you have a mask around it.
Yeah. That's exactly what I was going to say. You have a cloth covering.
Yes, and face mask.
See, even the pulmonary guy knows something about masks, Dr. Adiga. All right, next question.
Hi, this is Nate with the Health System. Good morning.
Good morning.
I've had this question come up repeatedly about UV lighting. Is it effective in killing COVID-19?
Larry and Mark, are you all using UV light at Advent and over in Truman?
We are currently. Our PPE supplies are getting better, so at some point in time, maybe in the near future, we're going to be able to not reprocess those. But we are using UV light to reprocess our N95s. We're using the Nebraska protocol, and it's we've been able to extend our use by at least 3 uses for each mask, so that's been helpful, especially early on when we were a little short on our N95s.
Yeah, Mark, how about Truman?
Yeah, we're doing the same thing here at Truman, and pretty much exactly what Larry said, using the same protocol.
And we've started doing some hydrogen peroxide work, Dana. I don't know if is anybody else doing that. You want to talk a little bit about the hydrogen peroxide approach with Dana, and we'll see how others.
Yeah, it's a vaporized hydrogen peroxide, and it's just very toxic and can kill, not kill, but destroy the virus. And so we were initially using some UV light, and then we were able to go to this other processor and just use the vaporized hydrogen peroxide. And I'm not sure if we're doing it right now, but it's going to be in the works, and
I thought we started, but yeah, we have a company that in Kansas City that's doing that. So, Anybody else looking at other forms besides UV light out there? Larry, or Mark, or Raghu?
This is Raghu. No, we're not using any of those for reprocessing. We're still using, the 5-day rotation of the mass for mass conservation that CDC has recommended. But we are using UV for, environmental purposes, not mask reprocessing.
Yeah. Good.
So here at Truman, we are exploring the hydrogen peroxide method as well, but we haven't started that.
Does it work at home? Hydrogen peroxide?
No, does it work? Can you do hydrogen peroxide at home, Dana, to reuse your mask?
Vaporized hydrogen peroxide is pretty toxic. It has to be done in a
controlled room, negative airflow, all that kind of stuff. Yeah, we would not recommend it at home. And if you dump it onto the mask, you'll make the mask really wet and destroy the mask. So then it won't help you anymore.
This is a very scientific process that it's undergoing. And again, it's the mask, it's not you, because we know that even small levels of hydrogen peroxide are pretty toxic to humans. So.
Yeah.
I also have a question about why not use a CPAP, a butyrol, other steroids like you do with flu to treat this?
Okay, so why not use CPAP, albuterol, or steroids, or other things? But so Larry, the CPAP is kind of controversial in COVID-19.
It is. It's come and go. When we first started, it was we want to intubate these. We want to put these people on ventilators early, and that seemed to be the right course. And then since that time, as you know, it had more evidence that perhaps that's not the right course. We shied away from CPAP to begin with, mostly because of the aerosolization of having that and putting that into the air, and said, we're better off if we have it contained. I think it's sort of swinging back and saying, well, if we can prevent perhaps putting these people on ventilators, the risk of having that aerosolization. Excuse me, can't say that word.
That's a hard word, aerosolization.
It's got several syllables in it.
Yes.
So that the risk is we're able to maybe take that risk and try to keep people from having to be on the ventilator. So you're right, it's a little controversial.
Yeah. Yeah, and I think you don't want all that secretions flying around the room. That's too bad. Not too bad. Albuterol is good. You can do treatments, but we're trying to do them with an inhaler as opposed to the albuterol that gets through your nebulizer, because that, like CPAP, can push the virus out into the air and in smaller forms. So, other questions? So as we kind of wind down today, I want to again say thank you to our guests, Mark and Larry and Raghu. Any last comments, guys?
Wind it up.
All right.
Yep.
So again, tomorrow we'll have our lab folks on to talk about testing and advances in testing, and then Friday we'll be talking with our nursing home expert as well as Senator Moran. Mm-hmm. For Dr. Hawkinson and myself, remember, even as we no longer think about having to shelter in home all the time, which may be coming soon, you still have to stay safe out there. So what you need to do mentally is start preparing for the world as it is and not as it was. Remember to maintain your distance, wash your hands, don't touch your face, cough into your elbow. Let's stay alive. We'll see you tomorrow. Thank you.
Thank you.
Thank you.